Well, hello, everybody. It's FitFoot U, and it's in honor of National Diabetes Month. And I feel real privileged to have the Dean of Diabetes himself, Dr. David Armstrong, both DPM and an MD, a professor at Keck, and he's going to tell us some exciting stuff that's happening with the grant that they were just awarded in the area of diabetes and keeping diabetics moving. I also want to say that we have in the show the founder and engineer behind a really innovative thing that I brought into my office, which is 3D print orthosis, orthotic producing. And Yong Li is the founder, and he's also working concurrently with a diabetic grade 3D printed orthotic that you would be able to do at the office. So David, why don't you start by telling us a little bit about this grant? Never happened before in healthcare. Tell us a little bit about it.
Well, yeah, there's actually a couple of grants, but I'll start with the first one. By the way, it's good to see everyone on this thing. And Dr. Li, really good to meet you. Dr. Privet, man, this is great. It's like old home week.
Same thing here. Thank you so much.
And for me, it's like adult daycare being on with you guys. So, I just kind of bump into things, and now I'm showing up on a Zoom here. But anyway, there's actually a couple of grants, but I'll get into both of them because they both have to do with sort of, I guess, diabetes in a way. The first is pretty broad. It's a National Science Foundation funded grant called the Center to Stream Healthcare in Place, or C2SHIP. And you can go to c2ship.org to find out more about it. And what it is it's actually the first ever industry university collaborative research center that's focused on streaming healthcare and healthcare in general. These are usually focused on things like supercomputing or planetary science or solar energy or geochemical stuff. This is pretty cool because it's designed to bring researchers together in universities along with industry folks, and to try to create next generation, not just startups but intellectual property and devices to help. What we would like to say is to maximize hospital-free days and activity-rich days. So that's first and foremost. I could talk about the other one in a minute. Well, it's a National Institute of Health grant, which is pretty fun, but I don't want to suck all the oxygen out of this four-person team here. Yeah. So I'll be quiet.
To follow up on that,
yeah.
Would that include some of the things that Bijan is working on as intellectual property in terms of gamification?
Yes.
Yeah. And I love that idea, by the way.
Everything's a game with Bijan. You've already so Bijan is one of the other. There are four now. There are four now. Five institutions that are involved. I'm the principal investigator at USC. And then we have Janet Riveda at University of Arizona. We have my friend Chiara Dario just down the road at Caltech. We have Bijan at Baylor, and now we're just getting ready to rock and roll with as in a formal site at the University of Missouri, and then following University of Missouri, also in the queue are UCSF and Stanford.
Well, I wanted to follow up with that because to me, making a task more fun is the key, I think, to compliance. And I know that there's also things that I think you've been working on with Bijan regarding family integration, which is, sort of peer pressure from the family, but in a good way.
Yeah.
One of the things that I wanted to also sort of dovetail on in terms of compliance, this is just something I've noticed both with diabetics and non-diabetics, is that when I have this orthotic print that Yong had me install in my office, I noticed that there is an immediate interest and engagement with my patients, because it's almost like Willy Wonka and the Chocolate Factory. You have the candy spinning out there, and it's literally spinning. And Yong will talk to us more. I think it's more involved than just nylon. It's a product though that he'll discuss. And what I have found as the key is there's a therapeutic moment where if you don't get the result, particularly with supply chain issues that we've had with COVID, you lose the patient. And I can't tell you how many orthotics I have sitting on my shelves from a very good lab, a central lab that I was using. But when I spin these things out, and here's a little cutaway of and I don't know if you can see it on this, but there's like almost a honeycomb effect, and you can define the density, you can modulate, you can put the Kirby skive in. We added a Morton's extension. Young worked with me on a full length orthotic. When you have that available in 48 hours, the difference is significant. And you know that you've worked with the zip ties on compliance, with offloading, where you have that, that breakage point where you know how the patient is done. So there's more of an immediacy to it. And before I bring you back, David, I want to just bring and introduce Young briefly, and then we're going to bring him back later again to sort of talk about what you perceive to be the future with this 3D print in terms of immediacy. So Young, take it away. Tell us about what you've noticed with the docs that you've worked with in Canada and in the US.
Okay, thank you. Thank you so much for everybody for taking the time. My background actually is automotive. I have been involved in like 3D scanning for clay model, for their design center, and also like engine block inspections for a long time, like over 20 something years. After I met Dr. Paul Langer, he's actually looking for 3D printing for custom food orthotic, and we sort of taking off from there to work together. So he's guiding me as medical director. I was just writing all the programs. Now we have a complete system which you can scan patient's foot by using iPhone, actually, or maybe iPhone or iPad, with a special mirror will attach to the iPhone with our scanning app. You can easily scan a patient's foot. Then push a button, we're gonna receive the file. Then we process them and send four files back to doctors. Doctors can review them and make modifications and then print in their clinic. So this is our system. So we have been working this for about 5 years, I think. So we got a lot of systems installed, both in US, Canada, and also UK, Australia, Japan, China, something like that. Regarding the diabetic, actually, we recently introduced, I sent Dr. Pearl a video, is a function we call the digital impression, because we try to create a sort of a total contact food orthotics for diabetic patient to offload or to evenly distribute the pressure. I wrote this program we call digital impression. Is after you got a scan, you can show the scan patient's foot on the screen. In the meantime, you can have sort of a foot orthotic underneath. Then if you push a button, that foot gonna step into the foot orthotic, create impression. So which is 100% match the patient's 3D shape of a plantar fascia surface. So this is, I think, yeah, it's my pleasure to talk to you guys because you guys are expert. I think maybe this is something useful for diabetic the patient care. I think definitely you need to put down top cover on that, because the material we're using right now, even though you can change how firm or how soft it is, but I think still you need to put a regular diabetic top cover on that. But it will create sort of a custom. It's like a food impression in a food orthotic.
And I wanted to bring your experience with this, David, too, because people in our industry that interface with Medicare. There's people that interface with DMER. So when we have like a standard 3-ply like this for diabetics, someone has to make the decision to approve an EVA with, let's say, a last layer of plastizote that would be applied. As far as you know, David, who does make those decisions? Is it just the interfacing of people like Paul Kesselman, I believe, is one of the people that does that? What is your thought process in terms of how these new ideas get approved for standardization?
Yeah, well, that's a great question. And, I think we could go on and on for an entire, you could have an entire
just
podcast
on that probably
on the Byzantine nature of, different, of how things go through kind of the pachinko machine of assessment and approval. But the good news is that I think that the folks at, whether it's a CMS, whether it's at the agency at FDA or others, these folks are, there's definitely not some evil cabal trying to stop this stuff. I think there are people that are genuinely interested in helping people. I think it's just very difficult and very complicated to get a lot of things through. And of course, with CMS, it's often a zero-sum game. But the actual, my experience with insoles and such, especially multi-laminar or multi-durometer insoles within CMS, is that it's really there really aren't any data to guide the current measurements, to my knowledge, even though, and I think a lot of these are based on best, medical opinion. Some of that opinion is very, very old. Some of it isn't. But I do think that they are taking suggestions, and it is getting better. I'm excited because I think I see, some segments of CMS, Center for Medicare and Medicaid Services, becoming interested in prevention, believe it or not. And even though, we used to say prevention, I was always frustrated because prevention doesn't seem to pay. But finally, I think that's starting to change with good quality, I think 3D and additive manufacturing and printing, good quality even remote patient monitoring. I think you're going to start to see some of these things merge together. So it's an exciting time.
I know one of the things that you've been intimately aware, and I think you did a fairly good comparison to a standard offload, and maybe you had something in the offload boot to total contact casting. And I think the results, although did you compare the two together, or was that, yeah. But there's
kind of a whole, there's kind of been a whole sort of safari in terms of these different studies over the last maybe 25 or so years. But just very briefly, there are a bunch of different for offloading wounds, not necessarily preventing them. That's a different question. Right. You see the really nice looking potential orthoses that Dr. Li has just showed. But if we're talking about healing wounds, what we have shown is that the total contact cast is sort of the gold standard device that you mentioned, and you heard Dr. Li mentioning total contact. And you're just spreading a force over a large unit area and to some extent up the wall of the cast. That works really well. It offloads about as well as anything else, but some things offload a little better, but it's about the same. Or better than anything else, and it seems to heal people about as well as anything else. However, people don't use it very much because in the past it's been hard to put on, hard to take off. There hasn't been a way for an office or clinic, if they use it, to break even on supplies, believe it or not. But that has changed over the years with easier methods to apply and even to remove. But still, even with that, maybe only about 10 to 12% of centers now around the United States or around the world are using that as a primary means of offloading. It used to be in 2009, 2010, when we looked at like 900 centers across the US, it was less than 2%. So that has really come along. But if people aren't going to use the cast as much, although it's my favorite method, there are what we call removable cast boots that work really well. And some of these things work offload as well in the laboratory. as the TCC, as the total contact cast. Unfortunately, they don't seem to heal people as well. We have often wondered why that is. About 20 years ago, about 15 years ago, we did some studies where we put, in the early days of what people call wearables now, where we put wearables on patients' waists, and then we put synchronized wearables on those removable devices. And we found, go figure, that these removable devices were being removed. and they weren't being applied again. They were only, people were only wearing these devices for about 28%, give or take, of their steps they took per day. And it's not their fault. It's not that they're trying to fool you or anything. It's just that, it's a big pain in the butt to wear these things. And the harder it is to put on, the easier, more you want to take it off. So pretty soon these things are just sitting next to your, people's lazy boy, like a beer cozy or something, just holding something, or a doorstop or something. So what we did was we took those, if people aren't going to wear the total contact cast, but they do wear the removable cast walker, but they remove it, then we thought, well, why don't we just make it less easy to remove? So we put a little zip tie or just a little cast or Coban around it. We call that an instant TCC. This is maybe almost 20 years ago now. And in some randomized control trials, we found, believe it or not, that folks healed about as well in both of those. But, and then I'll shut up after this. You'll be happy to know. We always thought that was kind of mean, because I don't know if it's necessarily mean, but it's like we felt like we're doing something to someone and not necessarily with them, even though we're talking to our patients as we do it. Wouldn't it be nice if maybe we could coax people into being a little more adherent, just like we were, the four of us have been discussing. So we have this National Institute of Health grant now. It's a great one, where we are randomizing people into 3 different things. Number one is this removable boot, like a normal one, good one. The second one is an irremovable one, the instant total contact cast, right? Zip. And then the third is kind of a smart boot. And it's just like the other 2, except it has an activity monitor on it. And it also is attached to a smartwatch, and it's given patients a little motivation. It's saying, hey, Ms. Garcia, thumbs up, well done. You're wearing your thing, or nah, not so good. Maybe you ought to put it on a little more. And we're able to review that with the patient and do things with them. All 3 of them, the cool thing is, have smarts in them, but only one is giving the feedback to the patient. And we're trying to follow that along with some other sophisticated activity monitoring. And Bijan and I are doing this, and it's a great study. And we've just started enrolling our first patients in November. So it's an exciting.
So you're creating more awareness, and that's, again, to a small degree, what I think is happening. When I have this orthotic print device right in the waiting room where people can see it, it gets them curious, and I see engagement even with the parents and their children. It's no longer, oh, the doctor is sending off to the lab to get my child orthotics. It's, oh, we're seeing this orthotic being made in the office. And by the way, Johnny's got some inline skating he wants to do, and we'd like to do that as well. And could that also do that? Now, Yong, I don't want to put the cart too far ahead of the horse, because your first project is to get a approved diabetic orthosis. I'm just thinking out of the box here. I wonder if there would eventually be a way that 3D print could also be part of a, maybe not fully, but maybe a 2-piece contact cast, maybe for the foot portion that could attach to an upper portion. I don't know. There's a lot of stuff that's being done with foam. Do you see that as a challenge? You've worked in the car industry as well. Now we're going up the full leg, and the return on an investment in trying to go full contact with 3D print in some type of clamshell or otherwise. Yong?
Yeah, we have to take a close look on that. It's probably doable. Break them down into like 2 or 3 different pieces and somehow assemble them together. People can wear that and walk. But I do think the most important thing is still the plantar surface. If you can distribute the pressure evenly on that surface, that's probably the primary target we have to focus on in the beginning, I think.
Yeah, no, for taking things one step at a time. And Dr. Armstrong, David's outlined that that is a great preventative. It's just when you get to the point where you actually have open ulcerations that you have to take that chain of offloading up the leg. David, tell us a little bit about some of the general, since it's,
Ben,
go ahead,
Steve, away please. From this topic, a quick question. So David, you were talking about gamification before. Are you employing it in this study, and are you using any positive reinforcement?
Yeah, that's a great question, Steve. We're not using, we should be, I'll just say this, but we're not formally doing that. What we're doing right now, and this is a big problem, I think, because I think we have to focus just on this. Right now, what we're doing is we're just trying to ask the first basic question: can we give a little feedback to the patient? Thumbs up, thumbs down, really basic stuff that a person can see if they have, proliferative retinopathy or something like this, and then some feedback with the doctor and the patient as well. But to your question, which is a really excellent one, we have other projects where we're being a lot more active in how we sort of gamify, stuff. Ben has had Bijan on in the past to talk about this, but what we need to bring in, and we haven't done this well enough, we need to bring in not just engineers and physicians and surgeons and therapists and others. We also need to bring in people like I know this sounds weird, but like economists, behavioral economists, and marketers, and things that used to feel almost para-scientific or para-professional, but because they have discrete and domain knowledge that we don't in kind of identifying areas where we can, convince people to do what they know they should already be doing.
Yeah, there's very few cognitive economists, right? There's maybe two.
Yeah, maybe. Yeah, but I believe strongly that that this sort of thing, in terms of, and we're seeing so much of it in sports now,
absolutely,
and also in advertising. I think that kind of thing, those things to us, have felt initially kind of maybe not really even scientific. Who really cares what we call it? What matters is a quality result that we can measure and then help our patients move through the world a little bit better. Yeah, so that's a great question. And the answer is no, we're not doing it as well as we could.
Right. Yeah, the economic part is good for HH&S and for funding for sure. Absolutely.
Absolutely.
David, tell us a little bit about some of the big breakthroughs, because you're an MD as well, that you've seen in just glucose monitoring or other breakthroughs in diabetes that you think are exciting, since we're in National Diabetes Month. One of the particular things, and I've asked some people about this because I really don't know, how good are the sensors as opposed to the finger sticks? So you can start with that and then expand on to some of the other things.
Yeah, sure, Ben. And by the way, you want to get, so just last week or whatever, the weeks are like flowing together now. It's like with peri-pandemic time dilation. It could have been last year or 10 years ago. I don't know, but I think it was last week. My longtime friend and shortly yours, you should interview David Klonoff, Klonoff, David. And Dave is just a great guy. He's a diabetologist at UCSF, actually kind of in the East Bay, but he's also the president of the Diabetes Technology Society. And he just had a meeting. He just had his meeting last week or the week before. And wow, it was awesome. Every year, it just gets more and more fun. And we participate in that almost every year with all kinds of stuff. We did our whole foot selfie program that we were showing with our AI overlay and stuff. But he had a session, several sessions on really what is the cutting edge in this area now. And there really are just a lot of data on continuous subcutaneous glucose monitoring, on efforts to what we call to developing what we call an AP, or an artificial pancreas, which is really just a closed loop system, and that's been developed. People have been working on it for a while. But there are now, and I think in all of our clinics, our offices, we're seeing more and more patients coming in with a with their phone, and then with a little patch on here or on their belly, and they're just hitting now their patch with a with a near field communication or with Bluetooth LE, and that is.
And those patches are accurate for detecting sugar, and then
they are, and they're continuous. And what you're getting, and this has been around now. Things like this have been around for 20 something years. I remember Andrew Bolton, one of my mentors, and friends of ours that were working at that time, Sam Oibo and others, were looking at what's called an M value, which is like this kind of basically the excursion and sort of standard deviation of your glucose throughout the day. And, when you're measuring it 1,500 times, it's very different than if you're measuring it 3 or 4 times, where you might catch it at different times of the day. And we like to think of activity that we can measure now as very similar to glucose, where you can dose activity, like what we're talking about, by checking inflammation or your skin temperature, just as you might dose your insulin, or oral hypoglycemic or whatever, by checking your glucose. And so that's a similar discussion, but vis-a-vis the continuous glucose monitoring, this is something that is really exciting and getting better and better. We'll be working shortly. We're working on a grant right now with Roche, and we're tacking that on to some of our patients that are going into some of these offloading studies, where we're going to be measuring them continuously as well, which is super fun for a foot doctor like me and you guys too, because it's it's what are we really? We're in a lot of ways activity doctors, right? Our goal is to try to help manage and measure.
And I want to share with you, when you got me talking, or when I talked to you about the lecture you did with replacement organ parts, where you did that lecture out. It was almost like a TED talk. That really got me interested in regenerative medicine, not only for diabetic wounds, but in my particular niche that I like to do a lot of, sports medicine. Even though I got a lot of backdrop with coming out of a VA with wounds. It just so happens that I'm in a hospital that has a wound care center. So it really kind of siphons over to there. So, but I do enjoy sports medicine, and I've found big benefits. So I look forward to the time, David, when you can share this information, kind of like NASA, when those technologies apply to other fields of, a blender or whatever it is that is used commercially, where we will have adjunct things that come out of the research that you're at the forefront of. Yong, I wanted you to, and so before we come back to you for final word, David, I wanted Yong to take a brief tour of his lab, if you want to show us a little bit, because this is pretty cool. You want to show us around, Yong, for a minute?
Okay, so actually I'm standing in the lab. We have about like 30 3D printers. Some doctors, they don't want to print, they're too busy, so we print here. My camera is following me, so probably I'm blocking it.
You're good.
You can see this is all the 3D printers. I go this way. So we do a 3D printing all the time. So far we installed about like 200 printers. And
I want to tell you, I just want to share an anecdote. I had a nozzle that in shipping, it needed just a little adjustment. So rather than Yong have me painstakingly, get the tools that were needed, almost like a jeweler's tool, he just sent me out another nozzle. Fed Expressed it. I got in a couple days, and then we easily notched it together. And any delayed 3D prints, because he's also a central lab, he printed those orthotics out as well. So it's great to have that kind of support and backup for somebody that's really dedicated, not only to me as the provider, but the end user patients that we're servicing. So I just thought that was a great story. I mean, there's so many stories of, oh my gosh, this happened. And I'm just going to say, this happens to me with EMR, whatever company I'm using. And you are so lucky to be in an institution, David, because I doubt you have to deal with a lot of that, that interfacing, other than you giving your suggestions for how to improve things. But this is just a great company. Before we forget, I want, if people are interested both in 3D print as using it, how would they get in touch with you, Young? What's the best way to outreach you?
I can share my email. Maybe Dr. Pearl, you can share the email to
Yeah. So
everybody.
what is it? Just tell us.
First name is YONG dot LI at OLT foot.com. Yeah.
Okay. Well, listen, this has been great. And it's been such an innovation for my practice in terms of, like I say, the immediacy of patient satisfaction. David, I want to give you some final words for thoughts for the next year or two, because you're always, 3 steps ahead of everybody else.
I don't know who that is really that I'm 3 steps ahead of, but whoever it is, I'm probably stumbling ahead of them. Not really. So they're probably laughing at me like usual, just like my long suffering, much better half Tanya, with whom I'm going to go to dinner not too long ago from now. What I would say is that there's just so much going on right now that's exciting in our.
Where can we look for updates, David, on the studies?
Yeah. Oh, I think. Listen,
you'll publish them. We'll see them in PM News, etc.
It's just there's so much happening. We actually have a really cool think tank every Friday, and tomorrow we're going to have one of our buddies who's a executive at NVIDIA. NVIDIA is a they make cards and they make and they used to be in 3D gaming, and of course they still are for video cards. If you ever modded your own computer, if people still do that, but now, of course, because of their beautiful and amazing parallel processing, unsurpassed, now they're leaders in AI, and so that's what he's going to be talking about and efforts there. Weeks before that, we've had people talking about monitoring people with PTSD in their home and having to be able to improve care. Before that was, wearable robots and brain computer interface stuff. And of course, with us, all the tissue repair and wound healing and diabetic foot stuff. It's an exciting time. And so we see that like every week now with these characters that come on. So it's fun for me just to kind of hang out.
That's awesome. I always like to ask my guests what they're doing for exercise. So other than trump in the halls of Keck and run into your next conference when you get off a flight, what are you doing for exercise?
Oh, I do like 7 minutes. They call it a 7-minute workout every morning. It's just
in your hotel or wherever you are.
Wherever So I've been doing that as just J&J 7-minute workout. It's really fast. And then I walk like freaking crazy.
How about you, Young? What is your exercise of choice? I know I learned recently you were a soccer player.
That's a long time ago. I'm walking with my dog right now.
just focusing on the lab and walking the halls of the lab, I guess.
Yeah. Well, I got a husky, so
that's good. Run. You walk your husky.
Yeah. That is about as Canadian as you could get, man.
Yeah. The dog got a lot of energy, more than me, so they have to burn.
All right. Well, anybody have any last questions? Because I think we're at the 2-minute warning here for our session. And it's been great. And, probably a year up the road, David's always a great guest and he's always got stuff to share. So probably in a year, 9 months to 12 months, I'm going to get these results from NIH and the NSF grant and you can spill them out for us, David. Any last minute thoughts or questions?
I'll put in a quick word for both walking and Peloton. And David's programs and his lectures that he receives there, in addition to the ones he gives, sounds wonderful, particularly the AI computers and all that. I love it.
Yep. Well, we look forward to more of it. And thank you, David, for coming on. And thank you, Young, for helping to support this. I really appreciate it. And we'll get this out on YouTube for people to enjoy. And there'll be a blurb on PM News as well. Thank you, everybody.